Ma'am, we are on live now and we are starting the session, ma'am. So, very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. The topic for today's webinar is recurrent vaginal infection. I welcome all the audience. I request them to post their queries, if any, in the chat box so that we can have a short QA session at the end of the presentation. Now it's time to introduce our invited speaker for the day, Dr. Uzma Sultana, ma'am. Madam has done her MBBS MRCOG, and Madam is the obstetrician gynecologist at LF Women Healthcare Center, Shivaji Nagar, Bangalore. Madam has a huge experience in this division, and ma'am, I welcome you, ma'am. I'm handing the session to you for your further proceedings, ma'am.
Thank you. Thank you, Dr. Stalin. Good evening, everybody. I'm Dr. Uzma Sultana. I'll be talking about sharing some of my views about recurrent vaginal infection. I'll be starting the session now. Recurrent vaginal infection is a common, this one we'll be practicing in our day-to-day life. It's actually, I'll just be talking about normal vaginal flora. Just 2 minutes. No. Wait. Yeah. See, normal vaginal flora. There are many different bacteria usually inhabited in the vagina. Example, lactobacilli, which excretes hydrogen peroxide, creating an acidic pH environment, which is a natural disinfectant, acts to maintain the normal balance of organism in the vagina that is hostile to disease bacteria. Any condition that changes the vaginal acidity or disturbs the normal bacteria in the vagina may predispose to an infection. There's a delicate balance between the two major microorganisms, normally found in the vagina of women during their reproductive years. These microorganisms are Candida albicans. It's a type of yeast or fungus, and Lactobacilli species. Normal vaginal flora has a protective role, such as the protective role is played by estrogen, which increases the epithelial glycogen, lactobacilli, which makes this one acidic, and lactic acid maintains a pH, a normal pH. This pH becomes abnormal. The normal pH is about 4.2. It becomes abnormal if it is over 4.2. Aggravating factors are trauma, low estrogen, menses, alkaline seminal fluid, altered vaginal ecosystem causes epithelial desquamation. Ecosystem in vagina, which is estrogen, pH in the vagina is about 3.5 to 4. Vaginal flora, which is lactobacilli, which is acidogenic corynebacteria. The natural barriers against female genital tract infections are vulva, vagina, cervix, and endometrium. The definition of vaginal infection. Any overgrowth of bacteria which is normally present in vagina can cause a vaginal infection. The inflammation of vagina is called vaginitis. Vaginitis, which can be vulvovaginitis. It can be premenarchal, during reproductive period, senile vaginitis. During reproductive, it is divided usually infected by Trichomonas. It can be bacterial vaginosis and candidal infection. Vulvovaginitis in reproductive age group. Bacterial vaginosis, which can be 22 to 50%. Vulvovaginal candidiasis, it can be 17 to 39%. Trichomoniasis, which is 4 to 35%. Undiagnosed, can be 7 to 72%. The infection. Vaginitis is usually characterized by a vaginal discharge and or vulvular itching and irritation, and a vaginal odor might be present. The three diseases most frequently associated with vaginal discharge are bacterial vaginosis, trichomoniasis, candidiasis. Various diagnostic methods are available to identify the etiology of an abnormal vaginal discharge. The cause of vaginal symptoms usually can be determined by the pH and microscopic examination of fresh samples of the discharge. Laboratory testing fails to identify the cause of a vaginitis in a minority of women. Risk factors. It can be poor personal hygiene, obesity, using too much soap, uncontrolled diabetes, wearing clothes that are too tight, use of feminine deodorants, douches, and scented sanitary products, excessive use of antibiotics and hormonal contraceptive. It could be stress, it could be change in sexual partners, unprotected sex with someone infected with a sexual transmitted infection, pregnancy, recent childbirth, or menopause. It can be due to inadequate sleep or poor nutrition. Bacterial vaginosis. Bacterial vaginosis is a polymicrobial clinical syndrome resulting from replacement of the normal hydrogen peroxide producing lactobacilli species in the vagina with a high concentration of anaerobic bacteria, such as Prevotella species and Mobilinka species, Gardnerella vaginalis, and Mycoplasma hominis. Bacterial vaginosis, homogeneous, thin and white discharge. Bacterial vaginosis. It's characterized by thin, homogeneous, melodrous, frothy, white to gray vaginal discharge adherent to the vaginal mucosa. It's caused by an overgrowth of organisms like Gardnerella vaginalis, Mobilinka species, Mycoplasma hominis, and Streptococcus species. Bacterial vaginosis. For diagnosis of bacterial vaginosis, 3 of the following 4 criteria must be present. This is Amsel's criteria. Homogeneous, white, adherent discharge, vaginal pH higher than 4.5, whiff test, release of fishy odor from vaginal discharge with potassium hydroxide and clue cells. Vaginal candidiasis, second most common cause of vaginitis. It's caused by Candida species such as albicans, tropicalis glabrata. The risk factors are diabetes, pregnancy, broad spectrum antibiotic therapy, combined oral contraceptives, and steroid therapy. Pruritus is the most common symptom. Vaginal candidiasis, thick, odorless, white vaginal discharge, which can be cottage cheese-like, associated with valvular candidiasis with valvular burning, dyspareunia, valvular dysuria. Treatment of vaginal candidiasis. Antifungal vaginal creams or suppositories can be prescribed at a variety of doses and duration of treatment. Oral single-dose treatments such as clotrimazole 500 mg or fluconazole 150 mg is adequate. Longer course of treatment are needed when there are predisposing factors that cannot be eliminated, such as a steroid therapy. Recurrent or resistant candidiasis. Non-albican subgroup, other diagnosis, particularly herpes simplex, which causes localized ulceration and soreness, and dermatological conditions such as eczema and lichen sclerosis atropicus. Management, culture of the organisms, revise your diagnosis, extend course of treatment to 3 to 6 months. Trichomonas vaginitis. Trichomoniasis is caused by protozoan Trichomonas vaginalis. Many infected women have symptoms characterized by a diffuse, malodorous, yellow-green vaginal discharge with vulvar irritation. However, some women have minimal or no symptom at all. Trichomoniasis, third most common, caused by Trichomonas vaginalis, protozoa. It can be sexually transmitted, profuse, frothy, yellow-gray discharge, vulvar or vaginal erythema and edema, strawberry cervix, saline wet mount shows motile oval protozoa. This is trichomoniasis. This is the protozoa. This is this one which causes infection. It's a brief picturized this one of the infection. The complication can be bacterial vaginosis resulting in pelvic inflammatory disease that results in infertility and tubal pregnancy, increases in adverse outcome of pregnancy, such as premature labor, premature rupture of membranes, amniotic fluid infection, and low birth weight infants. Trichomoniasis may increase the risk of transmission of human immunodeficiency virus and may cause delivery of low birth weight or premature infants. Vulvovaginal Candidiasis. This is a picture of vulvovaginal candidiasis. Typical symptoms of vulvovaginal candidiasis includes pruritus, vaginal soreness, dyspareunia, external dysuria. None of these symptoms is specific for vulvovaginal candidiasis. It can be abnormal vaginal discharge, which is white, curd-like, cheesy vaginal discharge. Diagnosis of a vaginal infection. Diagnosis criteria, like history. In a normal person, there's nothing. In a bacterial vaginosis, you can see a discharge, which is bad odor, like a fishy, possibly worse after intercourse. Discharges are thin and gray, white. Trichomoniasis can be frothy discharge, bad odor like fishy, pain during urination, which can be dysuria, and it can be yellow-green colored discharges. Candidiasis causes itching during candidal infection. Discharge is clumpy white without odor. It is cottage cheese-like. The color of a normal vaginal flora is none. Bacterial vaginosis can be gray-white. Trichomoniasis can be yellow-green. And candidiasis can be clumpy white. For mixed infection, Gardnerella is the most bacteria involved and can be identified by formation of a Q cells. When you put a slide, it looks like this. The Q cells and the epithelial cells, the cell nucleus, and the bacteria which is infecting. In case of recurrent infection, culture must be done. Whiff test. Doctor use potassium hydroxide to detect which type of infection through putting 2 drops of potassium hydroxide with concentrate 10% or event culture and detect the type of infection through odor and color. This is a diagram of the pelvis. You can see the cervix, vagina, rectum, bladder. Swab is being taken, speculum is being used, and the uterus. You have to smell this one and diagnose. Recurrent bacterial vaginosis, defined as 3 or more episodes in 12 months, is called recurrent bacterial vaginosis. The recurrence rate is high and often involves frequent telephone calls and visit to the clinic. Multiple treatments are prescribed in the absence of curative therapy. Research suggested that recurrence rate of 58% of over a 12 months period in women treated with oral metronidazole for 7 days. The recurrence was associated with prior history of bacterial vaginosis, lack of hormonal contraceptive use, having the same sex partner throughout the study duration, and having female sex partners. The repetation rate as high as 30 to 50% within 3 months is designated as recurrent bacterial vaginosis. Recurrent trichomoniasis. Trichomoniasis is the most common non-viral sexual transmitted infection in women worldwide. Cases of recurring trichomoniasis vaginitis have been reported with recurrence rate as high as 5 to 8% within 2 months of initial diagnosis. It's associated with reproductive morbidity and increased risk of HIV acquisition and transmission. Patient may be asymptomatic or present with abnormal yellow-green vaginal discharge, inflammatory symptoms such as itching, burning, and dyspareunia. On examination, there may be erythema of the vulva, vagina, and strawberry cervix. Microscopy, if available, may reveal motile trichomonads. Nucleic acid amplification test is recommended for diagnosis of trichomoniasis. The treatment. Trichomonas vaginitis. Metronidazole can be given 2 grams orally in a single dose, or tinidazole 2 grams orally in a single dose. The cure rate is in treating trichomoniasis using oral metronidazole is 90 to 95%. In resistant cases, oral metronidazole may be repeated after 4 to 6 weeks. The alternative regimen is metronidazole 500 milligram orally twice a day for 7 days. Trichomonas vaginitis. Special consideration. In cases like pregnancy, vaginal trichomoniasis has been associated with adverse pregnancy outcome, particularly premature rupture of membranes, preterm delivery, and low birth weight. However, data do not suggest that metronidazole treatment results in a reduction in perinatal morbidity. Women may be treated with 2 grams of metronidazole in a single dose. Metronidazole in pregnancy is category B drug. There's no evidence of harm to the fetus, but no adequate well-controlled studies have been conducted. Recurrent trichomoniasis. In women who fail 2 grams metronidazole without evidence of reinfection, metronidazole 500 gram orally twice daily in 7 days is recommended. If treatment fails, tinidazole or metronidazole 2 gram orally for 5 days is the recommended treatment. If persistent infection is documented despite the previous therapy, without evidence of reinfection, there are case series and reports documenting success using high-dose tinidazole and compounded paramomycin in management of refractory trichomoniasis as follows. Tinidazole 500 milligram orally 4 times daily for 1 week, or tinidazole 500 milligram orally 4 times daily plus tinidazole 500 milligram vaginally twice daily for 14 days, or tinidazole 1 gram orally 3 times daily plus 5 gram of compounded 5% intravaginal paramomycin nightly, that's in the night, for 14 days. Vulvovaginal Candidiasis. Treatment for uncomplicated vulvovaginal candidiasis. Short course topical formulations such as single dose and regimen of 1 to 3 days effectively treats uncomplicated vulvovaginal candidiasis. The topically applied azole drugs are more effective than nystatin. Treatment with azoles result in relief of symptoms and negative cultures in 80 to 90% of patients who complete therapy. Vulvovaginal candidiasis. The recommended regimen for uncomplicated vulvovaginal candidiasis. Intravaginal agents. Butaconazole, 2% cream, 5 gram intravaginally for 3 days. Or clotrimazole, 1% cream, 5 gram intravaginally for 7 to 14 days. Or clotrimazole, 100 milligram vaginal tablets for 7 days. Or miconazole, 2% cream, 5 gram intravaginally for 7 days. The oral agents are fluconazole 150 milligram oral tablets, 1 tablet in single dose. Vulvovaginal candidiasis. The complicated vulvovaginal candidiasis, such as recurrent vulvovaginal candidiasis. Vaginal culture should be obtained from patients with recurrent vulvovaginal candidiasis to confirm the clinical diagnosis and to identify unusual species, including non-albican species, particularly Candida glabrata. The recommended dose is a longer duration of initial therapy. That's 7 to 14 days of topical therapy, or 100 milligram, 150 or 100 milligram oral dose of fluconazole every 3rd day for a total of 3 doses. That's day 1, day 4, and day 7. The maintenance regimen can be oral or where is it? Oral topical, oral miconazole 100 milligram, 150 oral fluconazole 100 milligram, 150 milligram, 200 milligram dose weekly for 6 months is the first line of treatment. Vulvovaginal candidiasis. Severe vulvovaginal candidiasis, that is extensive vulvular edema, erythema excoriation, and fissure formation, is associated with lower clinical response rate in patients treated with short courses of topical or oral therapy. Either 7 to 14 days of topical azole or 150 milligram of fluconazole in 2 sequential doses. Second dose 72 hours after the initial dose is recommended. Compromised host. Women with underlying debilitating medical conditions, that is such as uncontrolled diabetes or those receiving corticosteroids, who do not respond to short-term therapies. Efforts to correct modifiable conditions should be made and more prolonged that 7 to 14 days conventional antimycotic treatment is necessary. Pregnancy. Vulvovaginal candidiasis frequently occur during pregnancy. Only topical azole therapies applied for 7 days are recommended for use among pregnant women. Recurrent vulvovaginal candidiasis. In patients with azole-resistant vulvovaginal candidiasis, treatment options include intravaginal boric acid, that's 600 milligram daily for 14 to 21 days. Intravaginal 15.5% flucytosine vaginal cream, 5 gram daily for 14 days, and intravaginal amphotericin B, 50 milligram vaginal suppository daily for 14 days. Fluconazole can be given orally every 72 hours in 3 doses, followed by fluconazole orally 150 milligram weekly for 6 months, or miconazole 1200 milligram vaginally weekly for 6 months for patients who prefer vaginal route for maintenance therapy. Itraconazole can also be given orally twice daily for 3 days, followed by itraconazole orally 100 to 200 milligram daily for 6 months. Bacterial vaginosis. All women who have symptomatic disease require treatment. The recommended regimen for non-pregnant women is metronidazole 500 milligram orally twice a day for 7 days, or metronidazole gel, that's 0.75%, one full applicator, that's 5 gram intravaginally once a day for 5 days, or clindamycin cream 2%, one full applicator, 5 gram intravaginally at time for 7 days. Bacterial vaginosis, the follow-up. The follow-up visits are unnecessary if symptoms resolve, because recurrence of bacterial vaginosis is not unusual. Women should be advised to return for additional therapy if symptoms recur. Management of sex partners. The result of clinical trials indicate that a woman responds to therapy and the likelihood of relapse or recurrence are not affected by treatment of her sex partners. Therefore, routine treatment of sex partner is not recommended. Bacterial vaginosis treatment. All pregnant women who have symptomatic disease require treatment. The recommended regimen for pregnant women: metronidazole 250 milligram orally 3 times a day for 7 days, or clindamycin 300 milligram orally twice a day for 7 days. Current treatment option: antibiotics and antifungals remain mainstay of therapy. The recurrence rate is high and associated with side effects. Probiotics. Definitions. World Health Organization. The definition of probiotic: live microorganisms which, when administered in adequate amounts, confer a health benefit on the host. A bacterial strain that survives the stomach acid and bile, adheres to intestinal lining, grows and establishes temporary residence in the intestines, impart health benefits. Probiotic potential management of the action of this probiotic: inhibition of adhesion, immunomodulation, production of antimicrobial substances, modification of toxins or toxin receptors, competition of nutrients, reduction in bacterial translocation, anti-inflammatory signaling within the epithelium. Mechanism of the probiotic. This is lactobacilli and bifidobacterium. The competition and cooperation nutrients, bile metabolism, antimicrobial compound production, and competitive exclusion, etc. It acts on the intestinal microbiota. Metabolic interaction, barrier function, anti-apoptosis, tight junction, induction of mucins, etc. Intestinal epithelial cells, and this one acts on the innate immune system. Regulation of cytokine expression, modulation of phagocytosis, modulation of IDC maturation, modulation of T cell differentiation. So intestinal mucosa, it acts by the adaptive immune system. Vaginal probiotic, rationale to develop. Clear hypothesis about role of lactobacilli, clearly established protective role of lactobacilli. Lactobacilli are predominant in the vagina. Application can be topical, reaching high inocular and organopeptic consideration. Easy sampling, easy re-isolation of probiotic lactobacilli after application, already available. Vaginal probiotic clinical trials. Treatment of bacterial vaginosis with lactobacilli. 60% of women with bacterial vaginosis had a double-blind placebo-controlled trial. Immediately after completion of treatment, 16 on 28 women treated with lactobacilli had normal wet smear results. None of the 29 women were treated with placebo. Only 3 of the women who received the lactobacilli suppository were free of bacterial vaginosis after the subsequent menstruation. Vaginal synbiotic, the clinical trials. Therapy of bacterial vaginosis using exogenously applied L-acidophili and a low dose of estriol, a placebo-controlled multicentric clinical trial. Vaginal tablets, Gynoflor containing 50 milligram of lyophilizate of viable hydrogen peroxide producing lactoacidophilus and 0.03 milligram estriol. 32 non-menopausal women with bacterial vaginosis, 6-day therapy with 1 to 2 vaginal tablets daily. Cure rate 2 weeks after the start of therapy was 77% versus 25%. Cure rate 4 weeks after the start of the therapy was 88% versus 22%. A significant increase in the number of lactobacilli. The biological control of vaginosis to improve reproductive health. This is just a brief of all this whole slide. The human vaginal microbiota plays an important role in the maintenance of a woman's health as well as her partner and newborns. When this predominantly lactobacillus community is disrupted, decrease in abundance and replaced by different anaerobes, bacterial vaginosis may occur. In bacterial vaginosis, the overgrowth of anaerobes produce noxious substances like polyamines and other compounds that trigger the release of pro-inflammatory cytokines interleukin. And bacterial vaginosis can profoundly affect with different mechanisms. All the phase of a woman's life in relation to reproduction, before pregnancy, during fertilization, through and at the end of pregnancy, bacterial vaginosis can directly affect fertility. Since an ascending dissemination of the involved species may lead to tubal factor infertility. Exogenous strain of lactobacilli have been suggested as a means of re-establishing a normal, healthy vaginal flora. Carefully selected probiotic strain can eliminate bacterial vaginosis and also exert an antiviral effect, thus reducing viral load and preventing fetal and neonatal infection. The administration of beneficial microorganisms, that's probiotic, can aid recovery from infection and restore and maintain. Use of probiotic strain for the treatment of bacterial vaginosis. These are the treatment only with probiotics. Vaginal capsule containing 10 to 8, this is the slide, which contains lactoacidophilus or placebo for a period of 6 days. 21% cure rate compared to 0% in control group. Vaginal capsule introduced 1 to 2 times daily, at least 10 to the power 7 L-acidophilus and 0.03 milligram estriol 6 days, 88% cure rate compared to 22% in the control group for 4 weeks. In this, 32 women were taken. Daily vaginal capsule containing 10 power 9 L ramonosus. This was given either once or twice daily. Metronidazole gel for about 5 days. 65% cure rate compared to 33% in the metronidazole treated group. It was a trial for 30 days and 40 women were included. Vaginally introduced 1 or 2 capsules daily containing at least 10 power 9 CFU or L brevis. All agents were used for a period of 7 days. 50% was cure rate compared to 6% in the control group, which was used for 3 weeks in 34 women. And thank you. Thank you for giving me an opportunity to speak on this.
Thank you, ma'am. Thank you very much for that wonderful presentation, ma'am. You have covered a valid point for using these probiotics in vaginal infections, ma'am. Ma'am, let me wait for 1 or 2 minutes for that. Yeah, ma'am.
This shows probiotics play a very important role.
Yes,
very important role in this one.
Yes. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am.
Okay.
Queries will be good for you, ma'am.
Okay.
Ma'am, whether this tinidazole is safe in pregnancy, ma'am, when we are using tinidazole?
Yeah, it is safe. It is safe.
Okay.
But nowadays, most of them usually are coming down the lane to pre and probiotic for bacterial vaginosis, everything. On the whole, they treat.
Okay, ma'am.
Because very few go for a culture and test and all.
Okay.
Especially pregnant ladies, they don't welcome so easily.
Okay. Ma'am, whether probiotics is safe in pregnancy, ma'am?
Yeah, it is safe. It is safe.
We have one question, ma'am. How long we have to take these probiotics and how long it takes to see the results, ma'am?
Yeah, usually probiotic is given either for 1 or 2 weeks.
Okay.
If you feel the infection is too much, 2 weeks is better to be on the safer side.
Okay. Ma'am, which one is better, oral probiotics or vaginal probiotics?
I feel oral is much better than the vaginal.
Okay. Participants, if you have any queries, please post here so that I can take it to the speaker. So participants, if there is no queries, then we can end the webinar. So I can take another 1 or 2 minutes. If there is any queries, please post. Ma'am, what about this herpes infection, ma'am? When it is when it is due to this herpes virus,
Herpes.
Yeah, ma'am.
See, when you have an herpes infection, along with this, you have to give oral or acyclovir should also be given. It should be covered for literally about 2 weeks orally. 800 milligrams should be given per day, and 2 weeks should be given along with the topical applicants also, because it's a painful and a long process.
Okay, ma'am.
Yeah.
Ma'am, how does this vaginal infections affect infertility, ma'am?
Vaginal infections, actually it's an ascending infection. It goes and blocks the tubes. It acts on the tubes and blocks the tube, and it can cause infertility in the patient. And then supposing if there is an infection even during a pregnancy time, there can be premature labor, premature rupture of membrane, ascending infection. These all things can occur.
Okay, ma'am. So bacterial vaginosis is one of the major cause for pregnancy loss also, yes.
Yeah. Early pregnancy losses.
Yes, ma'am. So, ma'am, fine, ma'am. There are no other questions in the chat box, ma'am. If you allow us, then we can end the webinar for today, ma'am.
Okay, thank you very much.
Thank you very much for being with us and spending your valuable time with us today, ma'am. It was a wonderful session. And ma'am, and we are looking for many more interesting webinars from your end, ma'am. So please do this.
Hopefully. Okay. Thank you.
Audience for their active participation, and do stay with us for upcoming webinars.
Sure. Okay. Thank you very much, Dr.
Thank you very much, ma'am.
Okay. Bye.
I'm ending the webinar.
Okay.